And as you say, Faisal, there's a plethora now of portable ECG devices that we can use in our clinics, and also patients are now using for sort of remote detection in their home. But I quite like the idea of a device, an ECG device, integrated within a blood pressure machine, because that can
Mm.
really further help address the unmet need. I mean, for me, it's always made perfect sense for patients with hypertension to be routinely checked for atrial fibrillation at the same sitting, because hypertension, as you say, is not only a serious risk factor for developing AF, but can also further increase the risk of having a stroke in AF patients, as well as, of course, increasing the risk of bleeding once AF patients are anticoagulated. So, I mean, that's a perfect marriage, isn't it, to have a portable ECG device integrated within a blood pressure machine?
Yeah, no, you're absolutely right. I think, and we touched on it earlier on. Of course, we talked about risk factors of AF, and hypertension. Of course, is a big one. And so, if you have a blood pressure monitor, and that blood pressure monitor device can also give you an ECG, that's the perfect marriage. Because what you do want to know, of course, is that, yeah, you can diagnose atrial fibrillation, but actually, does the patient have hypertension as well? It's an important thing to detect, and hypertension is also going undetected as well. So if you can detect two disease states with one device, that's perfect, because then you really can make informed decisions. So even if even if you don't detect AF, but actually they're checking their blood pressure, and the blood pressure is high, you need to intervene and treat that. Similarly, if patients are detecting AF, and you find hypertension, or if you even if you don't, these are important factors that will help manage your AF as well. Because if we know that hypertension is part of the CHA2DS2-VASc score that we use when we decide whether to start anticoagulation. And then a good example would be, a young patient, for example, who's say 50, who has atrial fibrillation detected, and then what do? You need to know about the CHA2DS2-VASc score, and you'll look at other things as well. But if they have a device and they come back and say, actually, I've taken BP readings on several occasions, I've averaged out, when I'm relaxed, and I'm getting consistent readings that are 160, 170 systolic, say over 90 diastolic, well, you know immediately that, hey, that this patient's going to be at higher risk. So without any further ado, you can look at the other risk factors within the CHA2DS2-VASc scheme, but you know that their score is going to be at least one because they have a hypertension. You should start them on anticoagulation as soon as possible. So I think the marriage between hypertension and AF in these devices, it's a perfect opportunity really to tackle two very, very common disease states which interlink and both relate to each other and will impact how they're treated. So, I think these devices really, really can be a game changer. I really do.
Excellent. No, really, really excellent points. And I think very exciting that we have access to these technologies to really help streamline the diagnostic pathway and hopefully lead to sort of earlier diagnosis. So finally, Faisal, can you give us any tips to sort of our primary care colleagues? Let's say we picked up the atrial fibrillation. I think the mainstay treatment of stroke prevention, I would suggest most GPs are fairly comfortable now at sort of overseeing that in most patients. There may be some patients with comorbidities that require a bit of secondary care input on that. But what about the other aspects of atrial fibrillation management, the sort of rates or rhythm control? At what stage do we need sort of secondary care input to decide what is the optimal strategy in that regard?
Yeah, again, another very, very good question, Yasser. So, again, colleagues, I think primary care have become better and better at managing atrial fibrillation. Historically, if we go back 15, 20 years, it was difficult because we had warfarin and not much else, and that was difficult to manage. And in Coventry, I can give you our local experience. Our local GPs in Coventry weren't commencing anticoagulation. We had a warfarin, dedicated warfarin clinic where patients were coming in, starting, having bloods taken, regular INRs, difficult to manage, and GPs really were reluctant, understandably, to start warfarin and to manage it because it was so difficult to do. But with the advent of the NOACs, or the DOACs as they're now called, and with other agents on the horizon, it's become much, much more easy. These agents have reliable therapeutic targets that you get to take a pill either twice a day or once a day. You take them regularly. You don't need regular monitoring. The interactions are no longer as much of an issue as they were with warfarin, and patients prefer taking these tablets compared to the old agents that we were using. So all of that can be managed in primary care, and our primary care colleagues are now much happier taking that on. And, you know, as you said, there will be instances where they might think, oh, actually, I might need a bit of secondary care input, and that's fine. In terms of managing the AF itself, again, all the evidence suggests that if you're, you know, determining whether there's somebody who's for rate control or rhythm control, if you go down the rhythm control strategy, which often is the case, then get in there early with your treatments. You know, there's a lot of trial evidence that's been published, you know, showing that early rhythm control is better rather than delaying it. And when people come to things like, you know, either antiarrhythmic drugs or interventions like AF ablation, which I do a lot of here in Coventry, then the earlier you get in there, the better. The longer you wait and wait for the AF to go from paroxysmal to persistent, and particularly if it then becomes long-standing persistent, i.e., it's been there for more than a year, it's much, much harder to then get them out and to keep them in normal heart rhythm with whatever strategy you might choose to use. So that early management, that early intervention of going in and deciding how you're going to manage them, rate or rhythm control, depending on the patient in front of you, and particularly the rhythm control strategy, I think the earlier you get in there, the better. Again, here again, giving the Coventry example, here in Coventry and Warwickshire, we have a community AF clinic that we started last year. And so patients are referred from the community and also from secondary care from other specialties, where they're seen fairly quickly in a one-stop clinic by arrhythmia nurses. They undergo an echo at the same time. They have a diagnosis made, and if they need an AF ablation or antiarrhythmic therapy, it's commenced, and it's overseen by EP consultants that based here in Coventry. And that sort of approach actually is bringing secondary care out to primary care in a way. And I think that approach is actually very efficient because you're seeing patients a lot more quickly. You're kind of intervening. You're providing a one-stop strategy if you can, where you get the full assessment by arrhythmia nurses who are very well versed in AF management and aware of all the latest guidelines. And you get their echo done. You've got all your answers, and you can formulate a plan very, very quickly. And if it is AF ablation that's needed, they are listed. And we know that the problem, of course, everywhere throughout Europe and certainly here in the UK, waiting lists for AF ablation are massive. You know, they're up to 9 months, even a year in many places, and we're no different here. So if you can get onto an AF ablation list earlier and get your AF ablation done quicker if it's indicated, that's going to give you better outcomes. So I think we may end up seeing more and more of this integrated working between primary and secondary care.
Absolutely. I think that has to be the sort of long-term sustainable solution. So thank you very much, Faisal. We sort of come to the end of our
Pleasure.
time today, provided some real nuggets of practical advice for us in primary care, and reinforced, like in most areas of medicine, you know, the better outcomes when you start treatment sort of early. And the key to that improving of outcomes, particularly in atrial fibrillation, is getting that diagnosis in a timely fashion, preferably through sort of opportunistic and targeted detection by patients at home. So thank you very much, and look forward
Pleasure.
to
My pleasure.
the next meeting.
Likewise. Thank you very much. Yes, thank you.